So this is a continuation of the lecture that I gave not too long ago. Really today we've already covered kind of the how people get nauseated. I mean, just a little bit. It's a really complicated structure was really the take-home message from the last lecture. There's a lot going on both centrally and peripherally, and that's why we also don't have a one-size-fits-all drug that really kind of fixes this. And so we'll look over some of the treatments basically for post-op nausea and vomiting. And this goes not just for in the phase 1 of PACU, but also like phase 2 and same day and things like that. So you can run into this. And also, surgeons have total free reign to send people home with nausea, vomiting stuff. There's a new term that I discovered while researching this. PDNV, I think it's called, post-discharge nausea and vomiting. And so it's basically when patients get home, how miserable are they and what kind of, problems can ensue. Okay, so we're going to talk about different pharmaceuticals and just drugs we can use. A lot of these you're probably going to recognize because we use them a lot. So the first category I'm going to get into is the serotonin receptor antagonists or blockers. Biggest example that everybody knows is Zofran. I'm not real sure why that specific one is so incredibly popular. The other ones are a real expensive version of Zofran, basically. I don't think any of these, at least in this top half, are any better than the others. But there's Zofran, Sancuso, and Anzimet. Anzimet's used a lot in chemotherapy and stuff. And then there's a newer one called Aloxi that is at the bottom. We'll go over that here in a second too. So Zofran, dosing is basically 4 milligrams IV, which you guys see all the time. If given orally, you double that. I had no idea. I've been giving people 4 milligrams of Zofran all the time. Didn't know that you can double it up. This is best if given 30 minutes prior to the end of surgery. There are certain situations where we want to give that in pre-op if it's going to be a short procedure. But Zofran doesn't last real long, and so you don't want to waste too much of it during a procedure when the patient's asleep anyways. The big drawback of Zofran and all of these drugs in this category is that it does prolong the QT interval on EKG. So if you run into a patient that already has like congenital long QT syndrome or something like that, this is usually the first drug kind of stuff that gets cut out of the anesthetic. A lot of anesthesia medicines prolong the QT interval. And so what you don't want to do is skimp on any of that stuff. This is kind of your luxury item, unfortunately. In researching this, I found a new one, palonosetron, I'm going to say. I don't know. Aloxi sounds way easier to say. So this new class of medicines not only has a higher binding affinity for the receptor, which theoretically should mean it works a lot better, but also has a way longer half-life. This one has a half-life of 40 hours. So we're talking long-term nausea, vomiting control for like a day or so, at least a therapeutic concentration after one dose. So that'd be really cool if that kind of gains traction. It is approved in America. It is being used for chemotherapy stuff. It is about, I think I looked it up, like $20 a vial or something like that, $27 a vial. That's in the expensive range, considering Zofran's dirt cheap. So that's probably why it's not used a whole lot. We'll move on from there. Glucocorticoids. I don't know if all glucocorticoids have an antiemetic property. I do know that dexamethasone, also known as Decadron, does. It is kind of another very popular medication for postoperative nausea vomiting prevention because it is just so well tolerated. You give 4 to 8 milligrams IV, depending on just what you want to do, I guess. It's best if given at induction. Dexamethasone is a really long-acting steroid, so it takes a while to kick in. So the studies and things that basically say Dexamethasone at the beginning and Zofran at the end is kind of how I approach things. And like I said, this is super well tolerated in lots of people. Another really fun side effect, it can actually reduce pain, postoperative pain. That's backed up with research and things like that. I have absolutely no idea how that works, but it does. The problem is you have to give high doses of it, 10 to 12 milligrams. You can get higher doses than that when you're looking at tonsillectomies and things like that. We give super high doses of Decadron. Per studies, this can reduce postoperative nausea and vomiting up to 72 hours, so that's also awesome for not only the PACU stay, but if the patient goes home. I'm assuming it's closer to the 72-hour mark with a higher dose, because that is also going to stay more therapeutic for longer, I guess you'd say. Biggest complaint people, not anesthesiologists, but surgeons want to, or at least harped on for a while, was we don't want to increase wound infections, right? Steroids block the action of the immune system, so we don't want to do anything that's going to cause, somebody's getting hardware put in for an orthopedic procedure. We don't want to increase wound infections because that's a really big deal. A single dose of a steroid does very little to alter that. Negatives, hyperglycemia can occur. I will say I have not seen any evidence whatsoever, even in pretty poorly controlled diabetics, that a single dose of dexamethasone will alter their diabetes so much that we've put them in some sort of danger. You know what I mean? Yes, their glucose will be elevated for a little while, but it shouldn't impact A1C or any of those other, metrics.
Significantly elevated?
Right. It shouldn't be real high. You know what I mean? Now, if they're already 300, yeah, you're going to go up to 400 something, and they will get higher, but it was already pretty high. You know what I mean? If somebody has well-controlled diabetes, I have not seen a big difference between giving a single dose of dexamethasone versus just the surgical stress of having surgery. Because any of those diabetics, you have surgery, that's going to release cortisol, that's going to be a similar sort of thing. And so that alone is going to cause some hyperglycemia. But I am not aware of, and I'm kind of hedging my bets on this because I'm by no means like Mr. Research Guru looking for these things out on the internet. You know what I mean? I'd be very interested to see that would be practice changing. You know what I mean? But I don't think so. I think this is still fine with diabetics. There's definitely some diabetics that I would look at and be like, nah, you don't get this. You know, again, it is a luxury item. It is not a necessity. There's other things we can use. Another negative, this can cause tumor lysis syndrome in cancer. For those of you that don't know, tumor lysis syndrome is where a bunch of cancer cells die all at once and release all the intracellular contents into the bloodstream. Potassium, phosphate, proteins from the rest of the cell and stuff. Can really beat up your kidneys. It can cause a big problem. So you would see this a lot more with us when we're doing spinal punctures for kids with chemo, bone marrow, biopsies, that kind of stuff. These kids are in kind of the throes of their cancer or whatever, and you don't want to thump them with a lot of steroids because that's what happens. It will also alter lab cell counts for multiple things. Your CBC, it's going to jump up your white blood cell count. It may also alter lab cell counts for things like the lumbar punctures. So there's times that we don't want to use it, basically. But it's pretty well tolerated in most people. Anticholinergics, scopolamine, scope patch. Scopolamine is a really cool drug. It is really only now found in a scope patch called Transderm Scope. And for whatever reason, they spell scope without an E, which drives me nuts, but whatever. Transderm Scope. Other anticholinergics are Benadryl, glycopyrrolate, and atropine technically work as well, but the gold standard is scopolamine. Why is that one better than the other ones? Maybe not so much Benadryl, but scopolamine very easily crosses the blood-brain barrier. So, like I said, it's a very interesting drug in that it does that. And that, I think, is how it exerts most of its effect in antiemetic like properties. The downside is it makes you crazy. So we used to have, in this country at least, IV scopolamine. And so if we had a trauma come in or something like that, or something really bad, where we want the patient to not remember any of this horrible surgery that's going to go on, but they're so unstable we can't give them anesthesia, we would give them IV scopolamine. It would hold their heart rate up, and they would just be like laying there in a stupor while they got like an X-lap or something. It was, I've done that once. It was in residency, and it was on a dude who was getting a nephrectomy for kidney cancer, and somehow or another they bagged the inferior vena cava, and like blood just went everywhere. So we had to turn off the gas and give him a bunch of IV scopolamine. You cannot get IV scopolamine anymore. You could probably understand why a manufacturer wouldn't want to make that anymore if that was the only situation that it would be used. You know what I mean? Pretty niche. But you run into this problem with like older people that get scope patches and pre-op, and then they won't wake up and pack you, or they're acting crazy and pack you or something. That can cause a lot of confusion, agitation, delirium, delayed emergence, all that stuff. So the scope patch is 1.5 milligrams. You apply it to the skin. We put it behind the ear. I don't think it exclusively needs to be behind the ear. I think it could really just be anywhere. But it seems to be relatively protected back there, so I accidentally fall off or get scraped off or something. It's good for 72 hours. So that medicine will last for 72 hours under normal circumstances. And the best thing to do is apply it the evening prior to surgery so that that skin can get a nice depot of that scopolamine, and it can have very regular absorption properties. However, 2 to 4 hours prior to anesthesia seems to be okay too. I used to tell patients if they didn't already have a scope patch on by the time they got here, then it was just kind of worthless and we shouldn't do it. It's not really true. You could also put it on just for like patients that have a lot of issue with opiates, right? We're going to send you home. You're going to have like your arm fracture fixed or whatever. We're going to send you home with opiates and you're going to heave for the next 3 days. Or we could just give you a scope patch here and help prevent that. So that's a good thing. Something of note. If you are to, this goes for any transdermal patches, nicotine, fentanyl, this. If you are to, like, let's say, place a bear hugger on a patient intra-op, and you heat that thing up, you will cause not only blood vessels to dilate around that area, but you will cause that medicine to get absorbed way faster into the skin. And you can actually make someone toxic with that. So that's something to consider as well. If a patient had like an upper body bear hugger on during surgery, if they're in PACU, they're not waking up or something like that, or they wake up and they're crazy as hell, then you can start to think that maybe the scope patch has something to do with it. It is very important for a provider to hand that off to any PACU nurses that they have a scope patch, because that can cause issues. If you do run into a problem with the patient, you want to get the scopolamine off, take it off, get a bunch of alcohol wipes and just wipe that area a bunch so that you can, I think the alcohol will probably inactivate it. I don't know that. I'm kind of spitballing there. But clean it off, clean the area, give it a little bit. That's all you can do, really. Yeah. Any questions thus far about that or any other medications?
So if you do have somebody who has a patch on and they're having this delayed emergence, would taking the patch off, would that really have much of an effect, or is what it is at that point?
It kind of is what it is. You just don't want to make it worse.
Right. Okay.
You want to like stop the offending agent type thing. This is also, again, kind of a luxury item, right? If someone is having some sort of delayed emergence issue and we're trying to figure out what's wrong with them, take the patch off. Like, we can always put another one on if that wasn't the answer. You know what I mean? And it's not, very economical or anything, but it's an option. So you do have to just wait for that skin depot to kind of get flushed away, in other words. So no, it's not a great quick fix, but it is something that you can do to really, at least stop it from getting worse,
How soon should you see a change in the patient if that does happen and take the scope patch off? Like, do you see something within a couple hours, or is it?
Maybe an hour or so, I would say. I'm not entirely sure, and maybe it's one of those everybody's a little bit different type things. There are medicines that we can do to kind of unmask this. I don't know the availability of it here, but we use neostigmine and glycopyrrolate to reverse neuromuscular blockade. And we give the glycopyrrolate to kind of offset the neostigmine type thing. But there is another drug called physostigmine. I think it's physostigmine that crosses the blood-brain barrier and could theoretically reverse some of the anticholinergic effects of this. So I've seen that used before in a PACU setting to kind of wake people up, and it totally works. It's really weird, but it totally works. You can also just start pulling off other things too, and that delayed emergence is like this whole other lecture. But you can use things like Narcan to kind of pull that part off, and that may be just enough to make them wake up. Even though the scopolamine is the main problem, we're going to pull off all the narcotics and kind of see how that works. So there's different things you can do in the meantime, but I think the key is to just, stop the offending agent. You know what I mean? Any other questions from anyone thus far? Okay. Antidopaminergics. So this is an area I didn't really know a whole lot about until coming to Montana. There was a very classic drug called droperidol that I remember talking to some of my attendings. By the time I got into anesthesia residency, this was already pretty much dead. And so I never got to use it. I've never used droperidol. But I heard it worked really well as an antiemetic. Droperidol is, I'll get into that here in just a little bit, but haloperidol seems to be something that we use here decently frequently. A dose to make someone very obedient and kind of out of their mind is like, I think the vial is 5 milligrams, so I guess somewhere close to that. But if you just give like 1 milligram, like a very small amount, that helps with post-op nausea and vomiting. That can be given IV, PO, or IM, and that's just haloperidol specifically. There's also droperidol and then amisulpride, which is Barimcis, which I have used that before and it helps. These are best if given at the end of surgery in kind of a Zofran fashion, like as you're closing type thing. So I mentioned droperidol isn't around anymore. So droperidol a long time ago got a black box warning of sudden cardiac death, which as you can probably imagine, a lot of people are like, well, I'm not using that anymore. So it would cause, I think it was just QT prolongation, but probably a longer, more dramatic amount of QT prolongation. And so they said for a while, you've got to monitor someone's continuous EKG for hours after its use. I think at one point it was like 24 hours or something like ridiculous. Now, or at least per whatever on here, it's 2 to 3 hours. Well, you can imagine if you're trying to get people in and out of PACU, that's not going to work real well. We don't want people sitting in PACU that are awake and ready to be either discharged or go to the floor, but we can't do that because we have to monitor their EKG for X many hours afterwards. All right, guys, I had to jump in real quick and just mention something else about the droperidol controversy thing. I'm going to be... I get this information from Wikipedia, okay? So it's pretty upfront public information. So in 2001, the FDA changed the labeling requirement for droperidol to include a black box warning citing concerns of QT prolongation and torsade. The evidence for this is highly disputed, with only 9 reported cases of torsade occurring in 30 years. And all of those cases, the patient received a dose in excess of 5 milligrams. QT prolongation is a dose-related effect, meaning that the higher the dose you give, the more significant the degree of QT prolongation. And it appears that droperidol
was not really much of a significant risk in low doses. A study in 2015 that showed droperidol doses given for violent and aggressive adult behavior, similar to haloperidol. This study in 2015 showed droperidol is relatively safe and effective for the management of violent and aggressive adult patients in hospital emergency departments in doses of 10 milligrams and above, and that there was no increased risk of QT prolongation and torsade. Of course, for postoperative nausea and vomiting, we're giving way less doses. So that's just something to kind of consider in this whole situation.
So that is why that kind of fell out of favor. I heard it is coming back in popularity a little bit. I don't know if this is like a thing you can get around. That's a recommendation, so you don't have to do it. But if something goes wrong, someone's going to ask why we weren't abiding these like recommendations for this drug. So I don't know where the status is on that. Until then, we'll just use Haldol. It seems to work pretty good, I guess. Neurokinin 1 receptor antagonists, or NK1. The big one here is called Amend, that I've started using more and more of for patients that need a little bit extra PONV prophylaxis. So the generic term is aprepitant for this. The IV formulation is fosaprepitant. Rolaprepitant, which is Varubi, I guess, is another one. So the dose for this, for Amend, is just 40 milligrams, give it preoperatively. It's a long-acting thing, so you only have to dose it once. Per some of the stuff I was looking up, there was a meta-analysis that was quoted as saying this is the most effective and actually benefits the patients the most out of all single antiemetics, which is pretty high praise considering there's so many. It can also cause a lot of the fun issues that some of the anticholinergics can cause: confusion, agitation, delirium, those sorts of things. So heads up on that. But in the times I've used it, it seems like it works pretty well. It is not quick acting, from what I understand. So the recommendation is to give it pre-op, and that's it. So I don't know if this works real good as a rescue antiemetic. I haven't looked that far into it. But it is definitely something we can get before surgery that'll help out with things. Antihistamines also help reduce nausea and vomiting. One y'all maybe most Americans are familiar with is Dramamine, dimenhydrinate, which I don't know if we have here, but I would love to look into that to see if that is something we could dose, because it's pretty well tolerated by people. It makes them sleepy, is like the big side effect, but you're going to have general anesthetic. You're going to be sleepy anyways. Diphenhydramine, which is Benadryl, that is also used as an antiemetic. When I was at Arkansas Children's Hospital, we seemed to use a fair bit of that. The only problem is if someone, and this may be like a voodoo thing. This is like Corey's little weird thing. But if you give someone Benadryl or Phenergan or some sort of like drug known for its sedation qualities while they're still under a general anesthetic, they take forever to wake up. If you can wait till they wake up and then give it to them, they'll be sleepy, but they'll be awake. Again, that's not wonderfully science-backed. I mean, there will be synergistic effects from all these different sedating things kind of come together, but that's kind of my thing. Anyways, Dramamine, 50 to 100 milligrams PO prior to the procedure. Diphenhydramine, Benadryl, you can give 25 to 50 milligrams, which is a good dose. Timing wasn't specified in that. Because you can give that IV, kicks in way faster. If you've ever given someone Benadryl IV, it hits them pretty quick. So I'm willing to bet that that is more of an acute kind of thing. Similar efficacy to dexamethasone, droperidol, ondansetron, all the big favorites. So it does work. It's not super popular for use for this, but it does work. Phenothiazines, I love these. If anyone who's ever been sick and has gotten Phenergan, like at home or something like that, which maybe it was just me growing up, but like My dad was a physician, so we had like, I don't know, Phenergan laying around or something crazy. And so if I was sick, he'd give me some, and you just feel better. And you're really sleepy, but you feel better. So this is kind of one of my favorite rescue antiemetics, mainly because of that kind of drastic, I feel better pretty quickly situation. Another drug is Compro, which I think they use in the ER for migraines or something like that. I'm not really sure, but prochlorperazine is the other one. Promethazine, you can give 6.25 to 12.5 IV at induction. That seems to help things out. And then prochlorperazine 5 to 10 milligrams at the end. So that one kicks in a lot quicker. When I give Phenergan, and this may be why my patients feel better immediately / go to sleep immediately, is they come in a vial at 25 milligrams, I think, and I give the whole thing. So I guess you don't have to give nearly that high of a dose. So if I try to write you guys like a thing, it's like, oh, give them 25 milligrams of Phenergan. Remind me that evidence shows that 6.25 to 12.5 seems to work just fine, and that we don't need to put them into a small coma for hours on end. So negative sedation. You can get extrapyramidal side effects with this. It's not super common. Extrapyramidal side effects are not super common in any drug, but that is something to consider when you're looking at this. Cannabinoids, good old-fashioned marijuana. So there is a drug called Nabilone, Sesamet, that apparently is not THC, but still like derived from marijuana. Marijuana itself has been touted to have antiemetic properties. This apparently has antiemetic properties. It's given for chemotherapy-induced nausea and vomiting. However, I just bring this up, it does not work for postoperative nausea and vomiting. Don't know why. It seems to work in this situation, but not this other situation. That'd be really cool. But it's been tested, does not work. They looked at giving 0.5 milligram prior to procedures. It didn't make any difference. I'm sure there's going to be other stuff that comes out. Now that that's not like a super lockdown Schedule 1 drug, people are doing more research with marijuana, and they're going to see if it does anything different. That would be cool if they could come out with a drug that has like the analgesic properties of marijuana and the antiemetic properties, but not so much of the sedating properties. That'd be really cool. Get to work on it, science. Okay. Olanzapine. This is another drug that's kind of out of left field. I don't know why somebody started looking at this, but apparently it is a thing. Zyprexa is an antipsychotic. They give it to like old people that are seeing ghosts and stuff in their hospital rooms. And it does kind of work for that. This actually blocks the serotonin and D2 receptors. It's long acting, so you don't have to dose it real often. And so you give a dose of this, 10 milligrams pre-op, and that seems to actually help out with stuff. It does sedate, just like a lot of these antiemetics do, that act centrally. Propofol. This is a weird thing, but you can actually use this as a rescue antiemetic. Give them like a really small dose of Propofol and they feel better. Why does Propofol do this? I have no idea. Not real practical in PACU, because you basically just put them back to sleep, but they don't throw up, and sometimes can feel better when they wake up. So we took that evidence and started looking at things with Propofol to say, how can we like leverage this and maybe prevent post-op nausea and vomiting? So in the last lecture, we talked about using TIVA in order to do that, which is total IV anesthesia. So if you run a TIVA with Propofol, you have way less nausea and vomiting, and that kind of leverages that antiemetic property. So it does still have antiemetic properties, not as much, but when you just give it an induction to put people to sleep, it helps out just a little bit. And then, of course, running running an infusion for maintenance. This does work at subhypnotic doses for both adults and children. Like I was saying, if they're in PACU, you can give them just a little bit. They won't necessarily fall asleep, but they will feel better. You just kind of ride that thin line between it. I don't recommend like nurses having an order to give X amount of Propofol. It's probably a bad idea. That'll never happen. But just know that that is kind of a choice that's out there as well. Some of my cohorts, again, I never learned this in residency or anything, but when I came here, I noticed some people would run do a gas anesthetic, but then run like a propofol infusion as well, so they wouldn't need to run as much gas. And their justification for that was this will help out with post-op nausea and vomiting. So I don't want the pain in the butt of running a TIVA. I just want to get a little bit of benefit from running a propofol infusion. So it kind of makes sense in terms of like theory, but I guess this is being challenged in the literature because some studies show it helps, some studies show it's not helping. And so that usually means it's not helping, but I don't know. That's jury's out on that one. Reglan, metoclopramide, is another drug. This used to be like one of our mainstays. It still kind of is. I have an order in our PACU thing that's to give Reglan for people that are having post-op nausea. At best, this is weak. It doesn't really help that much. You have to give really high doses for it to work, and the higher the doses you get, the more extrapyramidal symptoms you're going to get. This one, I think, is more known for extrapyramidal symptoms than like Phenergan or any of those other ones. So the recommendation from the up-to-date article was to only give when other antiemetics cannot be used. It's kind of a, your final safety net type thing. I don't know. I still give it from every now and then to kind of make me feel better, I think, is more what it is. But I don't think it really helps people that much. So that is another thing that I learned from here. I thought it was like a great antiemetic drug, and as I dove more and more into the literature, it's like, so-so. We just have, and maybe at the time that we had like very few antiemetics and we didn't understand the mechanism so much, this was looked at as a better opportunity. It really isn't. Versed. This is kind of odd, but there is not a small amount of evidence to suggest that people that get pre-op Versed have less nausea and vomiting. What's the mechanism behind that? How does that work? I don't know. Hits similar receptors that Propofol does. So maybe that has something to do with it. Inconclusive literature. This is not like a cut and dry thing. This is something just being looked at. So I'm a little more prone to pre-med people if they have bad nausea and vomiting with Versed, especially if I think they benefit from it from a Versed standpoint, right? But maybe that will help. Okay, so what about non-pharmacological techniques? What about other things? I'm not real big into, I think we talked last time, I'm not a big woo-woo guy. I'm not a real big crystal healing and things like that. But there's some really weird stuff out there that does seem to work. We'll start off with acupuncture. As much as I don't want this to work, apparently it does. There is a spot on your wrist called P6. If you're into acupuncture, you probably aren't listening to this lecture, but you probably understand these points better than I do. But a few finger breadths up your wrist, like here or so, there is some sort of point right on the flexor carpi radialis tendon is what I have written on there. Really small. That tendon next to the palmaris longus tendon, I used to know like forearm and hand anatomy, and I do not anymore. But anyways, somewhere along like 3 finger breadths up from your actual like wrist is this spot that can be stimulated, and that actually does help with post-op nausea and vomiting. And it is not just acupuncture necessarily that works. You can do acupressure. One of the old wives' tales or whatever, one of the old tricks is that if you're like getting seasick or something like that, take an ice cube and put an ice cube on your wrist. And that may just distract you enough to not throw up. But this says, and it's 2 different meta-analyses that have looked at this. This is a repeatable medical study or medical world that does this. This is blowing my mind because I've always not really laid a lot of stock into acupuncture necessarily. I know it does some really weird stuff for pain and all that, and if it works, it works. Cool, that's neat. To my knowledge, no one at this institution knows how to do this. I don't think I know how to do this. I could probably learn, but I'd probably just be stabbing someone. So we'll probably leave this to the experts, but this is a thing out there. PACU nurses, where you at? Alcohol wipes, right? Who hadn't heard of this?
Why not?
This is a thing. I don't know how someone figured it out, but if you can open an alcohol wipe and get someone to just smell it, like just that alcohol vapor for a little while, a lot of PACU nurses will do this while they go get whatever antiemetic they're going to use, so that the patient doesn't puke all over the place while they're gone. This does seem to work. It reduces the actual need for rescue antiemetics, meaning that it would theoretically have a longer kind of duration of action than what looks like. So it, I don't know, it is a short-lived thing. When you take it away, it does seem to not work as well. But it reduces the need for rescue antiemetics, which are kind of contrasting ideas there. But that's what I found on it. It is less effective than standard antiemetics, but it does seem to work. The good keys on this, it is readily available. The alcohol swabs are everywhere. It is low risk. To my knowledge, this does not have side effects or any other problems, right? So this is something that I would highly recommend in PACU, just again, because there's not really a lot of downside to it. Use this on your patients. Rescue therapy. There is not a standardized, use this for rescue therapy, use that. I said earlier I liked Finnegan. I can't really back that up with like studies or science or whatever. In terms of at least what this article, what the up-to-date article was saying, is that antiemetics are antiemetics are antiemetics. Some work better than others, and some take longer to kick in than others, but there's not a single algorithm or anything like that to dictate how to dose that. Like what would be the best antiemetic we can use in PACU isn't necessarily very cut and dry. So it's kind of the Wild West out there in terms of this. The basic rule that they gave out was don't repeat a medicine that they've already had. If they already got, and this is probably really popular, if they already got Zofran Introp and they're still having problems with nausea and vomiting, maybe don't give them more Zofran, because we kind of already tried that. They have that on board. Look for another category of those 40 other categories that I just named to see if that will help them out. That's the recommendation on it. They said Zofran was really good for rescue stuff. It's non-sedating, so that's like the big benefit, I guess, over a lot of these other drugs that do sedate. They did say don't use Decadron. It doesn't work for rescue antiemetic stuff. That one is pretty strictly prophylaxis. So if someone's already nauseated, giving them Decadron probably doesn't work. So that was kind of the take-home message from what was written, very little on that. And that's all I got.
All right, guys, thanks a bunch for watching. Hit the like button if you like this content. If you want to see more just like it, hit the subscribe button. Make sure you hit the bell to get notifications. We'll see you next time.